Thank you.
We move on now to another very important topic. And for this, we have Dr. Rakesh Sahai. I would like to introduce him now. Dr. Rakesh Kumar Sahai is a very well-known personality in the field of diabetes and endocrinology in India today. He's the president-elect of the Endocrine Society of India, and he's the vice president of SAFES, former secretary of Endocrine Society of India. He's held many positions, received plenty of awards, and has several publications to his credit. He's a very good speaker, and today he is going to talk to us about the role of Vildagliptin 100 milligrams OD in type 2 diabetes with high HbA1c. Over to you, Rakesh.
Thank you. Thank you, Dr. Neeta, for the kind words of introduction, and thank you for inviting me to be here. And also thanks to the entire IDEC team for having me here. I should also congratulate you for the excellent program being conducted. I'll now move on to the presentation. I'll be speaking about, is my slide visible?
Yes, it's visible.
Yeah. So I'll be speaking about the role of Vildagliptin in particularly the 100 mg OD in terms of therapy. So basically what I would like to highlight here is that Vildagliptin is a very a good DPP-4 inhibitor, which has been available to us from a long period of time. I mean, and it has been one of the earliest DPP-4 inhibitors that got introduced into the Indian market, and we have seen a significant increase in the use of DPP-4 inhibitors over the several years, while the newer agents have also come in with the introduction of the SGLT2 inhibitors, which have several cardiovascular and renal benefits. We still have DPP-4 inhibitors as a sheet anchor in the therapy of management of type 2 diabetes. And today, while we're going through this pandemic of corona, we were already in the pandemic of diabetes, and the COVID scenario has actually caused a significant increase in the glycemic burden of people with diabetes. We could see that the HbA1c levels of the entire population of diabetes has gone up significantly, as was even seen in several different studies conducted during this period. And we are seeing that we are facing a significant burden of hyperglycemia amongst these patients with diabetes. And how does this category of drugs, the DPP-4 inhibitors, which bring about a control of diabetes without increasing the risk of hypoglycemia and without causing weight gain, fit into this entire scenario of managing patients with type 2 diabetes. So if you look at the algorithm today regarding, in the management of diabetes, we know that whether you look at the ACE algorithm, or whether you look at the ADA ESD algorithm, or you look at what the European Society of Cardiology is saying, or across different societies, and even if you look at at our own Indian guidelines from the RSSDI and the Endocrine Society of India, we are speaking of metformin as the first line of therapy. And then when we come at looking at the agents to be chosen to be combined with metformin, when metformin alone is not enough in managing our patients with diabetes, we always look at different classes depending on their characteristics. We do not say that the second line should be one particular class of drugs. It has to be individualized to the patient's requirements. And if you look and what across various guidelines, what we are today seeing is that based on the evidence that is available for the SGLT2 inhibitors and the GLP-1 analogs, we speak of using them as the preferred second line agents whenever there is established ASCVD or CKD. And in some situations, we would also think of replacing metformin also in this scenario. If we have a good glycemic control with metformin alone, we may even think of using these agents ahead of metformin also. So this is what the current scenario is. But in patients who do not have established ASCVD or CKD, that's almost about 60% or 70% of our patients coming to our OPD. These are not the very long-standing diabetics. They are the ones who are having diabetes for an average, say, 4 or 5 years of diabetes, and not having established ASCVD or not having CKD. In these patients, what is the choice? In these patients, certainly what we are looking at is we are worried about about weight gain in such patients, because most of our patients, even though they may not be obese, they are significantly having abdominal obesity, and we are concerned about weight gain, because even a single kg of weight added to their to added causes a significant metabolic disturbance. And therefore we are looking at agents which cause minimal risk of weight gain, and they have a low risk of hypoglycemia also, because hypoglycemia also has been shown in different studies to be a harbinger for the development of cardiovascular disease, and initiating and developing various arrhythmias, and can ultimately lead to significant increase in morbidity and mortality among patients with diabetes. So when you're looking at these agents, we are looking at the DPP4 inhibitors, which fit in very well here. And if you're looking at weight loss as a major goal, for a primary goal, then you're looking at SGLT2 inhibitors or the GLP-1 RA. And when you're looking at the cost, again, SUs was put in here, but what we see today is that there is a change in the scenario, with Vildagliptin going off patent and available at a much lesser price than what it used to be priced earlier. We see that there is a very significant increase in the use of Vildagliptin in this category, because cost is also now favorable for Vildagliptin. And this is how Vildagliptin fits in, not only in terms of these parameters that we spoke of, and also because of the cost of therapy coming down significantly. Now, coming quickly, I'll review the available evidence regarding the efficacy and safety of this class of drugs, or Vildagliptin as such. And if you look at Vildagliptin, we have seen that, I mean, if you look at DPP4 inhibitors as a class, we see that they bring about the reduction of HbA1c to the tune of 0.5 to 0.8% as monotherapy. And when they're combined with metformin, the reduction in HbA1c can go even up to as much as 1.3, 1.4% of HbA1c reduction. And this is shown in several different studies which have been done and with Vildagliptin. And we have data from these studies which are on the average about 6-month studies, which have shown that there is a similar benefit seen with when you look at Vildagliptin versus sitagliptin or any of the other newer gliptins. Now, if you look at differentiating between the gliptins, because we have a choice of 6 different gliptins available today, and if you're trying to, and we also know that the gliptins have a significantly greater benefit in patients of Asian origin. We see that as compared to all other ethnic groups, Asians tend to have a better benefit seen with the use of the gliptins. And also we also see that this is shown not only in one or two studies where we have seen that initially, but a meta-analysis of 55 clinical trials has shown that the glucose lowering efficacy of DPP4 inhibitors is higher in Asians than other ethnic groups. And the difference may be contributed by differences in the BMI, or it could be other factors which are hitherto not clearly understood. In addition, the insulin secretory defect is higher in patients with of Asian origin, because of the greater amount of visceral fat. For every given BMI or given waist circumference, we have a greater degree of visceral fat, we have lower beta cell mass and lower beta cell function, and that could account for the greater benefit provided by this class of drugs, which increase the insulin secretion in a glucose dependent fashion. If you look at effects beyond the DPP4 inhibition also, I mean, beyond the glycemic control provided by the DPP4 inhibitors, we also see that many of the DPP4 inhibitors have shown benefits in terms of bringing down the proteinuria, and this has been shown in different studies. And these renal effects of DPP4 inhibitors are shown in now quite clearly established with several, and we see that they can be used for although they have no clear evidence in terms of reducing the fall in GFR, but the reduction in proteinuria has been shown in different studies. But however, we look forward towards a better, well-designed trials like the ones which have recently been conducted for the SGLT2 inhibitors, with renal outcomes in renal outcomes being the primary outcome measures. And with such trials, we would be able to find out whether DPP-4 inhibitors, the benefit that is been shown in some of the trials in terms of the antiproteinuric effect can in turn, in fact, lead to reduction in the renal outcomes. Now, coming to the other aspect, trying to understand how vildagliptin can be placed amongst the DPP-4 inhibitors in terms of the choice between different the DPP-4 inhibitors. If you look at this meta-analysis of 69 studies, which had more than 28,000 patients, it was shown that vildagliptin was as effective as any other anti-diabetic agent, bringing down the HbA1c by 0.7% without increasing the risk of hypoglycemia. The concern regarding pancreatitis was also not shown amongst this 69 studies, which had more than 28,000 patients, and it was therefore concluded from these meta-analysis that vildagliptin is an effective and safe therapeutic option for patients with type 2 diabetes, both as a monotherapy and as an add-on treatment to either metformin or to any of the other classes of anti-diabetic medications. Now, looking at uh, a comparative study here, which is compared vildagliptin with sitagliptin and linagliptin. In this study, which was done in Chinese patients with type 2 diabetes who were not controlled on metformin alone, who were randomized to either of these three agents, vildagliptin group had the greatest reduction in HbA1c, and this was standing out as compared to the other two gliptins that were used in that study. It was 0.84% reduction with sitagliptin, 0.81% reduction with linagliptin, and vildagliptin, it was 1.33% reduction in HbA1c, which was statistically significant. And then there are other studies which have looked at, which was in the same study, what we also see is that the required insulin dose was lowest amongst the patients who were on insulin and who were randomized to these three drugs. So a similar study which looked at a combination of oral anti-diabetic medications and who were requiring insulin also. And in this group of patients, we saw that with the use of these three gliptins, there was a reduction in the dosage of insulin, and the reduction was probably to the greatest extent seen in the vildagliptin group. Now, what we also, when we look at the difference in terms of the adverse events, that is hypoglycemia or the other adverse events which are seen in some patients, is in terms of gastrointestinal adverse events and infections, the nasopharyngeal infections or chest discomfort. So these were the common adverse events seen in this trial when we compare, which looked at the comparison of these three gliptins, and there was no difference in the adverse events amongst the three groups of gliptins. Let's look at the verified, coming to the verified trial, which is probably one of the most landmark trials in the recent times, which looked at using a combination of vildagliptin metformin at the onset of diabetes, right from the onset of diabetes, trying to establish whether early combination therapy does provide a benefit in managing patients with type 2 diabetes, because we know that patients with type 2 diabetes often have been failed to get control with a single agent, and we progressively or sequentially add additional therapies. So this study was trying to see whether early combination brings about a change in terms of the durability of glycemic control. And what was the primary outcome was to look at the treatment failure. So the incidence of initial treatment failure during the 1 year period was 429, was 43.6% in the combination treatment group, as compared to 62.1% in the monotherapy group. So those who were getting a combination upfront were doing better, and they had lower risk of, they had almost similar or slightly higher risk of hypoglycemia, but they had both the treatments were therefore safe and well tolerated, but they had a greater degree of, greater duration of control, being achieved with the combination as compared to using only monotherapy, that is only metformin. So the use of vildagliptin in patients who have HbA1c in the range of 6.5 to 7.5 did lead to a greater a longer duration of control with this combination. Early intervention with a combination therapy of vildagliptin plus metformin provides greater and durable long-term benefits compared with current standard of care, that is initial metformin monotherapy for patients with newly diagnosed diabetes. So this has been a significant change in our thinking in terms of use of early combination of agents in patients with newly diagnosed diabetes. Now, let's look at some of these studies. The Vildal study, which looked at a combination of vildagliptin, addition of vildagliptin to insulin in patients with type 2 diabetes. And this was at 12 weeks of use of into this study, where the daily insulin doses decreased by 11% in the vildagliptin insulin group, whereas they increased by 2.3% in the insulin only group, with a statistically significant between group differences also. So showing that the addition of this agent to insulin does help in reducing the requirements of insulin and provides a better glycemic control. In fact, the risk of hypoglycemia was lower in the group that was receiving vildagliptin and insulin as compared to those who were receiving insulin alone, because the requirement of insulin was lower in the group that was receiving vildagliptin also. This is another study which looked at evaluating the effect of adding vildagliptin versus glimepiride to ongoing metformin on patients with diabetes who had symptomatic coronary artery disease. So what was seen was that in patients with type 2 diabetes and symptomatic CAD, the addition of vildagliptin to the ongoing metformin compared to metformin glimepiride therapy showed better glycemic control, lower inflammatory markers in the form of IL-1 beta and HSCRP, higher protective markers like adiponectin and HDL cholesterol, which are the protective markers, and improvement in the lipid profile. So overall, what we see is that the cardiovascular risk markers did significantly improve with the use of vildagliptin as compared to use of glimepiride. Now, coming to the effect of vildagliptin on glycemic variability, this is something which has recently become a very common parameter that is being assessed in many of our patients. We are assessing the glycemic variability by measuring the time in range, and let us look at some of the data on comparing vildagliptin with the other gliptins in terms of the glycemic variability. So this was one of the earlier studies which looked at comparison of vildagliptin and sitagliptin in patients who were undergoing the continuous glucose monitoring, and the MAGE values, if you see, were higher with sitagliptin as compared to vildagliptin, and the mean amplitude of glycemic excursion was the parameter which was very commonly used when this study was done, which was higher, which was significantly improved in patients who were receiving vildagliptin as compared to those who received sitagliptin. This is if you look at the blood, the fluctuations in the glucose levels, you could see graphically that there was a significantly lower glycemic variability in patients who were treated with the vildagliptin, and there were significantly lower postprandial blood glucose levels in these patients who were receiving vildagliptin. Does this lead to any change in terms of the cognitive functions and metabolic outcomes? So this was studied in a study which looked at patients with type 2 diabetes where addition of vildagliptin to was looked at in terms of studying their cognitive functions and comparing it to the metabolic control that was achieved. And since type 2 diabetes shares several pathophysiological mechanisms which are similar to Alzheimer's disease, studies reported antidiabetic treatments such as intranasal insulin, GLP-1 analogs, and DPP-4 inhibitors have been postulated to improve the cognitive function. And DPP-4 inhibitors may have dual benefits by improving the glycemic control and also having some degree of improvement in the cognitive outcomes. Now, coming finally to vildagliptin OD, which is the new kid on the block, which was approved by the DCGI recently in the sustained release formulation of vildagliptin 100 mg, was approved by the DCGI as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes. And let me show you some of the data which has looked at that. If you look at some of the PKPD studies, you look at the dissolution profiles of vildagliptin 100 mg SR formulation, we see that the optimized formulation F3 was the one which showed maximum release 98.43% in 10 hours of the dissolution studies, and this was the one which has been used in various preparations. And this is a study looking at Vildagliptin SR100 versus 50 mg BD, and this clearly showed the similarity in the pharmacokinetic profiles of Vildagliptin SR formulation, which showed a sustained plasma concentration over the 24 hours. And if we look at the other aspects of the pharmacokinetics also, we see that it has similar bioequivalence as compared to the Vildagliptin 50 mg BD dosing. There's one study which was published some time back, which was published quite a few years back in 2007 in Diabetes Research (DRCP), which assessed the efficacy and tolerability of 50 mg once a day, 50 mg twice a day versus 100 mg once a day. And this 24-week double-blind randomized multicenter trial showed had 354 patients who were drug naive with type 2 diabetes, and in all the groups, what we see was that HbA1c decreased progressively up to 12 weeks, and the adjusted mean change from baseline to endpoint HbA1c was 0.5% in the Vildagliptin 50 mg once a day dosing, 0.7% in the 50 mg twice a day, and 0.9% in the 100 mg once a day. And the percentage of patients achieving the target HbA1c of less than 7 increased proportionately with the dose that was used. So the adverse effects occurring in a significant number in all the treatment groups is listed here, and doesn't show any significant difference in between the three groups, that is Vildagliptin 100 mg once a day versus 50 mg twice daily or 50 mg once a day. The AEs probably were similar in all the groups. So this is another study which looked at Vildagliptin drug naive patients, 24-week double-blind randomized multi-dose study, looking at patients with high baseline HbA1c. There was a greater reduction with either 100 mg dose compared to with either of the doses. With 100 mg dose, it was much more than compared with the 50 mg twice daily or 50 mg once a day. So clearly, the 100 mg once a day does show a better benefit in patients starting off with a higher HbA1c of more than 8% at baseline. So I would like to conclude by saying that DPP-4 inhibitors achieve clinical meaningful glycemic control with lower risk of weight gain and hypoglycemia. Vildagliptin has shown greater HbA1c reduction compared to sitagliptin and linagliptin in some of the studies. Vildagliptin has shown better control of glycemic variability compared to sitagliptin in one of the studies earlier done. And Vildagliptin sustained release formulation has the potential of providing improving patient compliance along with effective glycemic control. So I thank you all for the patient hearing. I'll be happy to answer any questions. Yeah.
Yes. Thank you very much, Rakesh. That was a very nice and comprehensive. One second. Yeah. So there is a question here from Dr. Gagan Priya, where she asks that a thorough QT study has shown that slight QT prolongation just above the safe cutoff of 5 milliseconds with Vilda 100 and 300 at 1 and 8 hours, but not with 50 milligrams twice daily. So would this impact the the prescription and the safety of this formulation in high risk populations?
Yeah, so I think we just have this 100 mg introduced into the market, and I think we need to further look at some of these aspects like the QT prolongation that has not been adequately studied in the earlier studies, and I think there is need for such a study. But the one which you are mentioning is about comparing 100 versus 300. 300 probably had the highest prolongation. So I think we need to look at even the 100 closely and see the QT prolongation in these patients who are receiving 100 mg. But the earlier studies have not shown that convincingly.
Okay. So I had a question, Rakesh. Are there any head-to-head studies with Vildagliptin 100 milligrams OD, sitagliptin, and any of the other OD gliptins in terms of efficacy?
Yeah, I'm afraid that I don't think there are any studies like that which have been done, but there is clearly no need for that for these studies. The only study which I could find is that 100 mg OD was compared with 50 mg BD and the 50
Yes.
mg OD preparation. So there is a need for these preparations. These preparations have been focusing on the benefit in terms of OD dosing, and they've compared the pharmacokinetic properties and showed that they do as good as the 50 mg BD dosing. But what is clearly required is in terms of the clinical outcomes when you compare with all the other gliptins, whether you have any additional benefit or a similar effect as seen with sitagliptin OD or any of the other linagliptin once a day, as you have rightly mentioned. Yeah.
Right. Thank you. I don't see any more questions in the chat box. Thank you very much, Rakesh, for being here with us at IDEC. And we've really enjoyed your talk. Thank you so much.
Thank you.